Welcome everyone to today's virtual diaspora series brought to you by NgEX. Today we're going to discuss the COVID-19 pandemic and hear from Nigerians in the diaspora and in Nigeria that are actively involved in fighting the pandemic. We have a distinguished panel here, and I'm sure we have a lot of questions have been sent in, and I'm sure they have a lot to share with us. One good surprise, we have Honorable Abike Dabiri on the call as well to talk to us about yes. So she will talk to us about her commission's efforts in working with the Nigerian diaspora and also working with the issues around COVID-19. So welcome, Ma.
Hi, how are you, everybody? How are you, panelists?
We're doing well.
We're doing well, Ma.
Good
Thank
evening.
you. Welcome.
Thank you very much. Nice to talk to all of you this evening. Let me start by saying how proud we are of you all as Nigerians in the diaspora. When we hear about people like you, we're so proud that we're brothers and sisters. So I want to congratulate you, commend you, and let you know that you are the future of Nigeria. No matter the challenges in our country today, you are the ones that will make Nigeria a better place. So the Nigerians in Diaspora Corporation looks forward to working with you so we can build a better Nigeria. So as you all are at the forefront of COVID-19, we want to salute you and say we're proud of what you're doing, and hopefully we're going to engage a bit further as we move on. So I want to greet all three of you. Obina, thank you for putting this together. You know, I'm also always so proud of you. And where's Folari?
Folari is here.
Okay, Prof, by the way, let me brag a bit. Folari happens to be my nephew.
Oh, wow.
Incidentally. So I just saw his name on the panel. He happens to be my naughty nephew, but we're glad that he's now a professor of nanotechnology. My sister. So my sister there, I'm so proud of you. I mean, reading your bio, all three of you, honestly, I'm so proud to be a Nigerian. And you know what, like I said, we all have to work together. When you're done with all you're doing in America, Nigeria is still home. And we're not saying pack your bags and come home. We're saying whatever we can do together, wherever you are. Let's work together. So we're proud of you all. But before I go on, something happened today. We lost the chief of staff to the president. So I just want to say, can we observe a moment of silence and say, may his soul rest in perfect peace? Just a moment of silence, please. May his soul rest in perfect peace. So I look forward to this conversation. Obina, you go on, and you're just so young and youthful, and I'm so proud of all of you. Thank you so much for making us proud. Thank you very much, and God bless you all. Thank you.
Thank you.
Thank you.
Thank you, Ma.
Thank you, Ma.
Yes. Okay, so we'll jump right into it. So I'll start with the panelists, and I'll just ask each panelist to introduce themselves and a little bit about the background. So let's start from, I guess, our homeland. Dr. Okorocha, Dr. Uche Okorocha, if you can introduce yourself and just give us a little bit about your background.
Right. Good evening, everyone. Thanks, Obina, and thanks, Honorable Abike Dabiri. And then pleasure to meet all of you panelists. And good evening, everyone who's listening, or good morning, good afternoon, wherever you're listening from. Yeah, my name is Uche Okorocha. I'm a health management consultant. I'm based out of Lagos. And I think it's a good time to have the kind of conversation we're having today. I've been in various forums. I've listened to, I've participated in events of this nature, and I've come away with one thing, that the perspectives from outside of Africa are not as informed as they should be. So it's a good thing to see people who not only, they're not in Africa, but they have Africa at heart, so they can hear us. So thank you very much. In 2014, we participated in the Ebola fight. We learned a lot of lessons, some of which we have the opportunity to apply at this time. So as we go along in this conversation, I hope to share some of those with you. Thank you.
Thank you.
Yes, so if we can move to Professor Folarin Erugbogbo.
Yes, thank you very much for inviting me to this lecture, Obi. Thank you very much, Honorable Abike Dabiri. I'm trained as a chemical engineer. I got my PhD in chemical engineering, and I transitioned to biomedical engineering as a professor at San Jose State University, and I teach in chemical engineering, materials engineering, and biomedical engineering. And I've graduated many biomedical engineers, and one of the biomedical engineers that I graduated a few years ago was working very closely with Ethiopia on ventilators for COVID-19. She's leading a do-it-yourself initiative, and she kind of pulled me in as an advisor, and that's kind of how I started looking into the literature and looking into conditions related to Africa for COVID-19, and it was a very scary scenario, and I thought I have to be engaged in this. They have over 1,500 volunteers of doctors, engineers, and different professions that work together, and I'm working with them, guiding them on their medical device design, because that's what we focus on. I am traditionally trained in nanotechnology, and this comes into play because viruses are normally in the nanometer size range, and drugs like chloroquine have actually been studied in relation to nanodynamics, and those kind of inform the mechanism of how it might possibly help with COVID-19. I've worked with multiple different organizations, organized my own conferences and symposia, and even participated in the Diaspora Day Medical Panel in Nigeria in 2015. I serve as a technical advisor for some companies here in Silicon Valley that do biomedical work, and we have projects that are being executed in the Stanford School of Medicine and the UCSF Department of Anatomy and the UCSF Children's Hospital as well. I work with many different organizations such as the American Association of Cancer Research, or I'm a member rather, National Society of Black Engineers, and the Institute of Electrical and Electronic Engineers. And I'm looking forward to hearing what the panelists have to say and how we could further increase awareness to Nigerians in Africa in the diaspora on how they can contribute to the COVID-19 fight in the homeland.
Thank you, Prof. So we'll move to Dr. Kelechi Olejeme. Kelechi, please, if you can introduce yourself.
Hello, everyone. Good evening, Honorable Abike. Dabiri, nice to meet you. Thank you for being on this panel, and thank you, Obi, for hosting this. Also nice to meet all the other panelists as well. My name is Kelechi Olejeme. I am an internal medicine physician. So I take care of patients, primarily adults. I also have a master's in public health. I got that from Rutgers University. I did my residency in Atlanta, Georgia. And then I came to Texas, where I did a master's in clinical research, and I worked with MD Anderson for about 2 years before I started working as a hospitalist. So my primary job is that of hospital medicine, and I'm just going to explain to you what that is. When a patient is sick, they come into the emergency room and they basically come out with their complaint. If the emergency room doctor feels that they're not well enough to be admitted, they are discharged home. If a patient is sick enough to be admitted, they're admitted to the hospital and they become primarily my care. So I'm a hospitalist. That is the term used here in the US. And so that will take into cognizance the COVID patients that we admit. So when a COVID patient is admitted, they're admitted to my care, and I will take care of them primarily in conjunction with other specialists. So I'll be happy to share my experience with you on that.
Okay, thank you, Dr. Kelechi. Okay, we move to Dr. Chukwuebo. Dr. Chuk, please introduce yourself.
Good afternoon, and I must say evening, everyone, and thank you for hosting this panel webinar. And to the panelists and Honorable Abigail Debiri, thank you all. Thank you for participating. I feel honored to be part of this group. I must start by bragging a little bit also. I might be the person that I've known Obina the longest in this panel. We went to the same primary school and secondary school. I've known Obina for a long time, and both our parents were teachers, and our families were pretty close. Now, I went to University of Benin, where I finished my medical school, and I did my youth service in Kaduna, 1995 to 96. And I must say that was my first experience with an epidemic. I worked at the Tudunwada General Hospital during the meningitis epidemic in 1995-96. And right after then, I came to the United States and did my residency at the University of Maryland, Midtown in Baltimore. And after my residency, took the bold step to start a medical practice. And right now we have 10 physicians and providers. We have the largest practice in East Baltimore County with about 15,000 patients we care for. And I attend a hospital called MedStar Franklin Square, where I'm in line to be the hospital president of the medical staff in 4 years, where we have over 500 physicians, 3,000 employees, and 1,000 nursing staff. Right now at Franklin Square, we have an ICU floor of 96 beds with over 20 patients currently ventilated as of today. I am once again honored to be part of this panel, and look forward to contribute and also learn from everybody present here today. Thank you.
Thank you.
Okay, thank you, Dr. Chuk. And thank you for the introductions. So we'll jump into it again. So here, I just want to ask you all to, if you can just give us the background into what you're actually dealing with, in your profession with the COVID-19 pandemic today, right? What's your day-to-day interaction with the pandemic itself, right? Dealing with patients, handling the operation, or doing some research around it. So I guess we'll start with Professor, if you can just tell us, the kind of research that you're seeing. I know you talked about ventilators. How involved are you, and what kind of actions do you take to fight against this pandemic?
So the first thing that we've done in relation to this pandemic is actually try to provide information and understand it. The COVID-19 is such a generalization that a lot of people don't know what it is. And they're like, do we need this or that, ventilators? But a lot of people have mild symptoms. So the first thing is we try to get them to understand that when a person develops the cough or the fever, right, this is a result of the infection reaching the respiration system, the air passages that allow you to conduct air between your lungs and outside. That lining of your respiratory system can become injured. And the key term you want to think of is inflammation, because it causes inflammation. So you're trying to fight that kind of inflammation somehow. This then irritates the nerves in the lining of the airway, and you could actually have little particles stimulate the cough. So if it gets worse and goes all the way to the gas exchange units, which are at the end of the air passages, and it's exchanging the oxygen with the blood, you start having inflammatory material pour into those kind of air sacs that are at the bottom of our lungs. When those become inflamed, you get to a point where you end up with pneumonia. Now you're getting closer to the end stages, and then there's no particular solution for this. This is where people are trying to have all sorts of medications, and we're hoping that there are some various combinations of viral and antiviral medications that could possibly become effective. And the standard approach is to ventilate patients and maintain high oxygen levels. So one of the things we're doing is we're looking at all the open source ventilators out there. Now, a lot of these open source ventilators are ranked differently. They can be ranked in terms of how open they are. Can anyone get the plans to build this ventilator? Or how buildable is it? What is the community support? What is the functional testing? What is the reliability testing? What is the COVID-19 suitability? What is the clinician friendliness? What is the manufacturability? Now, what we realize is missing in the categorization of a lot of these ventilators is the reliability testing. So some people say, my friend built a ventilator, or they built a ventilator here. How do you know it's reliable? How do you know the oxygen levels are going to be fine? How do you know the pressure, the volume exchange is consistent? Those kind of things are what we're looking forward to or looking at dealing with, especially in conjunction with our Ethiopian collaborators. Then there are some more minor things because we are here in the USA and a lot of people can actually 3D print segments of devices. So for face shields, if you have a 3D printer, we have students that are currently printing those parts. They print the parts, they're shipped to a central organization that sterilizes them and then donates those kind of equipments to the healthcare organizations. And then I do a lot of nanotechnology. So I'm also doing research on nano formulations of encapsulated drugs that already exist that will be useful for this kind of COVID-19 treatment. In addition, we have about 60 students working on independent projects to contribute to these as part of their classwork. So that's part of where I am in this COVID-19 framework.
Okay. All right. Thank you, Professor Fulari. So Dr. Chooks, we'll jump to you. So if you can just tell us what your day, right, and within this pandemic looks like. What are you actually dealing with?
So, thank you. What I do is to work closely with doctors who take the stead of a panelist here, Dr. Lejame. She is a hospital medicine physician. Like I alluded to, we run a primary care practice and we have a clinic. Our population is mostly older white folks. We're in East Baltimore County, and we have over 5,000 patients who are over 60 years old, so patients who are at risk. So my job as a primary care physician and internist in the community, so you can see me as a GP or as the family doctor or an internist, jack of all trades that is out there and is in touch and in tune with the community. Our job is to reach out to the patient and encourage them to practice the social distancing. So we've been proactive in our care management. Encourage them to practice the social distancing, the hand washing, stay at home, limit visits outside the home, and avoid crowded spaces. Now, when our patients do have symptoms, they call our office, and we're fortunate to have 2 offices in 2 locations. So cohort of patients with COVID-19 symptoms to a separate location, trying to keep our main office sterile so that we don't cross-contaminate. Now, at the other office where we do see sick patients, we do testing. We do testing by nasal swab and send it to the lab for PCR. And like I was sharing with Obina earlier this week, because I've been home for a week now, actually, after a 2-week stint at the office doing testing, we take 10 days off, which is actually the Saturday and Sunday, the whole week, and then the next Saturday and Sunday, to try to make sure that you've not had exposure or symptoms to coronavirus before you re-enter the workplace. That's just our practices approach. Now, I was sharing with Obina that having tested lots of patients, most of them white and Caucasian, surprisingly, the 3 patients in my practice that I tested that tested positive to this were all Black males. And the 2 of them were actually Nigerian Black male in their 50s, because I do have a sizable Nigerian population given my long stay in this community, in my practice. And what has amazed me the most, and that's one part of medicine I'm most interested in, is population medicine, is how we are seeing in the data that shows up in Maryland, the state I'm in, that the folks most adversely affected by illness, morbidity, and death, mortality in a ratio that disproportionate to the demographics of the state are Black folks and Latinos in the state that is predominantly white, actually. And that is something that has struck with me all through my training here in Baltimore. For those of you who've watched the TV program The Wire, you know that Baltimore is a very rough city with a very poor and socioeconomically disadvantaged community. And we've seen that the Black folks, when they're sick, are sicker, and they die more from the COVID disease in our state. So thankfully, my 3 patients are doing well. They have not needed to go to the hospital to be taken care of by Dr. Legiman. So now in my practice, what I'm primarily doing is try to prevent the ER and the hospital from being overwhelmed. Imagine if my 15,000 patients went to the ER to get tested and they were not screened and they were not cohorted or directed, then the system gets overwhelmed. And that's when healthcare, basically the healthcare infrastructure breaks down. So in a nutshell, that's what I'm doing right now.
Amazing.
Okay, yeah, thank you, Dr. Chukwusebo. So we'll jump to Dr. Uche Okorocha. You know, you're out in Nigeria. So if you can just give us some idea into what you do, for at least I know you're on the operations side. So.
Right. You know, when this, when it looked like it was becoming inevitable that we were going to have to deal with this outbreak in Africa, especially in Nigeria. So one of my day job basically is to advise organizations, nationals especially, on how you prepare to respond to the kind of outbreak we have at the moment. What are the factors that will let you know that your risk level has increased? What measures are you going to put in place for every risk level? As the risk goes up, you have to put measures that will correspond to your risk level. So I provide guidance in planning a response for an outbreak of this nature. And then when it happens, we interact closely, monitor the risk, and then we also think about business continuity. Are we able to continue to work? To what extent? Who do we need? How do we keep people safe if they must continue to work, again, to whatever extent? And then things begin to improve. How do we scale back the measures we have put in place? How do we de-escalate? Those are the things that, well, I basically do on a day-to-day basis. However, I'm not a clinician. So in 2014, when we had to deal with Ebola, something became very clear. It became clear that quite unlike someone who has a heart attack who can call in an air ambulance and be evacuated overseas for treatment, with a public health situation like Ebola that we had, it was impossible for any organization to rely on their individual resources to take care of their employees and their families. So it became clear that we had to support the efforts of the government. Okay, that was one big lesson we learned. We had to pull our resources together and then support the efforts of the government. We make the government response machinery more robust and be a part of it. And so something happened though. A lot of the structures that were put in place in 2014, we don't see them anywhere today. Think about it. If the treatment centers and the ambulances and everything that we put together to respond to the Ebola outbreak were still there, it would have been a bit easier right now. Secondly, at that time in 2014, the outbreak of Ebola was in West Africa, Nigeria, Liberia, Sierra Leone. Okay, and so we have Doctors Without Borders, we had UNICEF, we had WHO, all focusing on West Africa. And so we had a lot of support in trying to contain the outbreak within the West African sub-region. Now, this is not exactly the case right now because those people are everywhere, okay? They're having to deal with a pandemic in this case. So we have to work a lot harder in order to deal with the issues we have. Also, at that time, the borders were not closed. Okay, it was possible to just order something easily, fly it in, whatever we needed, we had. Right now, that's not the case. So there's a lot of struggling. So part of what I'm doing is that I am mobilizing the private sector. I actually work with a group called RPF. We're mobilizing the private sector to get people, get individuals, get organizations to support the effort of the government. And I can tell you that they're supporting. However, there are some points I would like to mention. First of all, people mean well. People commit a lot of resources towards supporting the efforts of the government, but unfortunately, the resources are not optimized. Okay. For example, how do you know that what you are contributing is the priority of the EOC. EOC is the Emergency Operations Center, the response team at the state level, at the federal level. So we want to make sure that we are engaged with the EOCs at the various states. We want to make sure that the resources that people contribute are deployed in a timely manner. They are deployed in a transparent manner, so there is accountability. We want to make sure that these things are deployed to address the priorities. The priorities change every single day. Okay, today there is ventilators. Tomorrow you realize that the priority is not ventilators, it's something else. Okay, maybe just anything. It could just be PPE. It could just be stipend for volunteer trainee health workers, for people who go out to do surveillance and whatever. So we engage with them, and then we have to think about sustainability. There are some very nice things people are doing, and I have to say again, they mean well. However, think about what will happen after this outbreak. Are we going to just do things that the wind is going to blow away? And when outbreak happens again in the future, because it does happen, and then we start afresh. So my group is focusing on deploying the resources towards things that are sustainable. How do we strengthen the capacity of our teaching hospitals, of our big hospitals to cope with outbreaks of this nature in the future? So whatever we put in place today will always be there in the event that there's an outbreak somewhere down the line. So this is really what I'm working on right now.
Amazing.
Okay. Thank you, Dr. Uche Okorocha. Okay, Dr. Kelechi Olejeme, we'll jump to you next. You deal with the COVID patients directly. So please give us what your experiences are.
Okay, so like I said, I practice hospital medicine, and hospital medicine is practiced by several doctors, and there are several stages to treating the COVID patient. We have essentially divided COVID into 4 categories. There is the asymptomatic patient who doesn't have any symptom, but however just has a positive COVID test. We have the mild patients, the moderate patients, and the severe patients. So a lot of the times when people randomly do COVID testing, some of them, they're actually advised to stay at home. But a lot of people are anxious. They come to the emergency room and they say, my COVID test is positive. The ER doctor actually does a lot of the triaging right there. If the patient has no symptoms, their oxygen level is normal, we send them home. They go home. We tell them to take Tylenol if they have any symptoms, but they essentially go home. But they're told to come back to the hospital if their symptoms start getting worse. So the next category will be the mild patients. These are the patients whose symptoms are somewhat getting worse. They're having more of a cough, they're having more of a fever, they're basically not feeling well, they may have shortness of breath. They come to the emergency room and there's an assessment. Another assessment again is what is their temperature, what is their breathing status, what is their oxygen level. I'm not sure if you guys are aware of this, but COVID tends to cause what is called asymptomatic hypoxia. And just to break it down to lay terms, hypoxia basically means low oxygen levels. Asymptomatic is your oxygen is low and you don't even seem to realize that. A lot of people, when their oxygen levels are low, they start gasping for air. Your oxygen level should be more than 90%. But the ER doctors find patients whose oxygen levels are 60%, 30%. So those people are not asymptomatic. They're either mild to moderate. And based on that criteria, they have to be admitted. We also have other criteria for admission, but I'm not going to go into that. If a patient meets criteria for admission, I admit them. The ER doctor will call me and tell me I have a X amount of year man who presented with this symptom, would like you to admit him, and I'll admit him into the hospital. I go and assess the patient, and based on his presentation, I can map out a plan of care for him. If the patient needs a specialty doctor, such as an infectious disease doctor, we'll call an infectious disease doctor. If they have a lung problem, we'll call a lung doctor for them. If they're very, very sick, then we send them to the ICU. The treatment plan for the patient depends on what category the patient is. If the patient is a mild, is a moderate, or a severe, we map out whatever the treatment plan is for the patient. And so it's a day-to-day process. Every single day you see the patient, you reassess the patient and come up with a new treatment plan. And so that's essentially what we do. We keep the patient in the hospital. Once they start showing signs of improvement, we discharge them. But when they discharge, they're of course given instructions that they have to isolate, not quarantine at this time, but they have to isolate for 14 days. If they get worse, then I send them to the ICU and a different service takes over that. So my main role with the COVID patients is the day-to-day monitoring, the day-to-day treatment plan, and basically assessing and treating every other symptom they come up with. COVID has 1 million symptoms and every day is a new thing. So that's what I do.
Okay. Yeah, thank you. Just real fast, Dr. Kelechi, you talked about isolation and quarantine. We keep hearing those words and they're used interchangeably. Can you specify what the difference is between isolation and quarantine?
Okay, so quarantine essentially means that we have not proven that you have the disease. We're just assuming you may have the disease. So there is a general word out there to tell everybody to quarantine, which basically means you wear your mask, you stay 6 feet away from people, and then you do all the safety measures such as, washing your hands and all that stuff. But the main goal is wear the mask and stay 6 feet away. That is most of the quarantine. And then you don't go outside, you stay indoors. That's the quarantine. You don't interact with other people. Now, isolation is what you do in your own house. We now know you have the disease. You have tested positive for the disease. So what we now know that we're not just assuming you may have it or that you may spread it. We now know for a fact that you have it and you will spread it. So isolation means in your house, you lock yourself up, you go into a room by yourself. And you stay in that room by yourself. You don't sleep with your wife or your husband at that time. You don't interact with your family at that time. You don't have dinner with them. They bring your meals to you. You don't leave that room for 14 days. It's very hard, but the thing is, we know that you now have the disease and your chances of spreading it to your loved ones, especially, is much higher. So quarantining and you keeping 6 feet is no longer the plan. You now have to leave them alone and stay by yourself.
Obina, can I come in here?
Definitely.
Yes, can I just thank you all for the beautiful contributions. And I just want to say that between all four of you, I think we can have the solution to COVID-19. All four of you are a perfect combination. Just some quick questions. Starting with, and I'll go through all four of you so that I'll just ask my questions and I may have to leave subsequently. Starting with you, Dr. Kelechi. Now, thank you for explaining. I'm still confused about isolation and quarantine. So I just want you to take us through that again. So if you're taking to maybe where you have Nicole Stadium, is that isolation or quarantine? And
if you're taking to where?
Like you go to isolation centers, that's what they call it.
Right.
Like what do we have at the stadium? I think that's what we call isolation center. But you can also isolate your own home.
Yes.
So because we keep going in between those two, but thank you for explaining that. And then I want to ask you really, in terms of patient management, do you think we're getting it right as we're going on in Nigeria? Because we're still confused as to quarantine isolation. For instance, the Nigerians that say they want to come back home, we're saying when you come back, you still have to stay 14 weeks, compulsory isolation. Is that the right word to use? Because when you come back, you won't go home. You have to stay somewhere and then you spend 14 days there. So that's a question for you. Just expatiate on that. Is that, I think that's the protocol. Then Dr. Okorocha, I want you to, and I've been seeing you a lot, talking a lot in Nigeria about, and I've been seeing all the work you're doing. I want to talk about sustainability. It's quite a shame that in 2014, like you said, everything we put in for Ebola is gone. So what do you think we should do about that in terms of projection for Nigeria? How do you see us going? Looks like we're curtailing. How do you see us going? That's for Dr. Okorocha. Then Mr. Chooks, Dr. Chooks, jack of all trades and master of all. How stressful has it been for you? Then it's very interesting what you said about, Blacks being the victims where you're practicing. Is there an idea why that is so? Because it's very distressing for us to know that Blacks, fall victims a lot to that. So I want you to look at that and tell us how stressful it has been for you in doing all this. And then to Professor Falari, well, you are in the field of nanotechnology, and I'm sure you're looking at medication and solution. What do you think are the next steps? How do you think we can get maybe immunity, something to boost our immune system? And then secondly, how fast do you think we can get a vaccine for COVID-19? Then locally speaking too, here in Nigeria, and I believe in that, we cook agbo, mix it with pineapple leaves and something from farm and boil it. I've been taking it and I think it's working. So you're shaking your head, Dr. Kelechi. But in terms of, are there not things locally? Should we ignore what we have locally? Don't you think there are things around us? At what point will people like you be doing research into all that? So again, all of you. And somebody's complaining here about audio. So I think you should look about that. At that, some Galaxy 70 says the audio is not quite clear. So maybe you can look into that. So those are my questions for all panelists.
Okay.
Thank you.
Okay, so we'll start with Dr. Kelechi, I think, to respond first. But first, before we jump into the responses, just give some housekeeping. So for those on the call, if you have questions, we have a lot of questions. So if you have questions, feel free to use the Q&A and type in your question. We'll try to get to them. There are over 100 questions that have come in so far. Hopefully, as part of the conversation, they'll get answered, and then we'll also try to have a Q&A session at the end of it. Dr. Kelechi, please go ahead.
Yes, thank you for the question. I'm going to answer, I think your question was in terms of when people coming from out of the country and isolation. I know that nobody's flying anywhere right now, so people are not coming into most countries. I'm not sure if they're coming to Nigeria. My understanding was that everything was shut down. But yes, isolation can also be where, like I think when you get off, like if people come into a country and you put them in a hotel and you tell them to stay there for 14 days, that is all part of the isolation because they should not be in contact with anyone. And what I hear about those isolations is they don't come out of their room. They actually leave their food trays outside the hotel. The people take their food trays. I don't know what they do in different parts, but I've heard that those food trays don't actually come out. They stay in the room for the full 14 days.
Wow.
And so it's basically to minimize any contact. The reason why I'm told the food trays don't come out is because in the process of eating, you may contaminate the utensils, and whoever picks up that may end up exposing themselves by either picking up the tray. If the virus is on the tray, then they might expose themselves. So yes, the isolation would be you are by yourself, be it in a hotel, be it in a home, but you are essentially by yourself, and that is the right thing to do. Isolate for 14 days.
Thank you.
Okay. Was there another question?
I think you've answered my question. Thank you very much.
Okay, cool. Thank you.
Okay. Yeah, Dr. Uche.
Okay, yeah, thanks, Honorable VK. So let me just pick up from where Kelechi stopped. In Nigeria, we've not gotten to the point where confirmed cases who are not critically ill are allowed to isolate at home. We haven't even gotten to the point where they may go to any hospital that has the capacity to treat them. So our situation is quite different here. So here, everybody is taken to a designated treatment center, directly managed by the team for 8 days. That's the way it works here for now.
Okay.
And yes, people are managing to come into the country, and those people, when they do come in at the border towns, however they come in, they are quarantined or kept in isolation, supervised isolation for a 14-day period. And actually they are tested as well. And if they are free after that, they are allowed to come in and to meet their family and friends. So to your question, Honorable Abike, first was on sustainability, what we can do. What we can do is the kind of thing we're trying to do right now. Let's do things for for the TV moment, if you like. Okay, if we really want to do something, if we have made up our minds to commit our resources towards this cause, let's engage with the people who actually are dealing with it hands-on. Let's find out what they need right now, and then let's find out what we can do today that would be meaningful today and be there tomorrow. For example, I do not mean to disparage the efforts. You talked about the Nikon Stadium, but I just have a feeling that a stadium goes back to being a stadium after the outbreak. And I'm just wondering, okay, what's going to happen to all the investment? Now, but if we were to invest in making the infectious disease hospital in Yaba, strengthening their capacity, more ICU beds, more ventilators, monitors, whatever it is they need, training more people, setting up more laboratories that are capable of testing. These things will be useful right now. They will always be there when we need them, and then we won't have to start from the scratch. So that's my point. So let's engage with the right persons. Let's focus on strengthening the facilities that we already have. Let's do things that will last. I think.
Thank you.
Right.
Fantastic. Thank you. Thank you.
Okay. Cool. Okay, Dr. Chuk.
Yes, thank you, Honorable Dabir, for your question. It was stressful. It is stressful. It is stressful, and but it's also very rewarding. As a physician, we took an oath to do no harm first, but above all to care for our patients, and we do take it very seriously. On a personal note, I have 3 boys aged 14 to 8 who are home now, and they've been home obeying the stay-at-home order for non-essential folks in Maryland since March 12th. So while working 2 weeks, seeing sick people and testing them, I had to do all the grocery shopping in my home because I encouraged my wife to stay home, so that I was the only family member who left the home. I had to go to work. And before I got home, I stopped wearing my regular clothes, no suits, no ties, nothing, just scrubs. And I'll literally take them all off before I enter my home, through the basement, go to a basement shower, take a nice hot shower, and literally spend most of my day there with little contact with my family. I did have contact with them, but very little. I would make sure I washed everything and sprayed everything with soap and water and alcohol-based sanitizer before I made it up to the family floor. And that was for 2 weeks. So I've actually been home now, like I said, for a week, the whole of last week, and tomorrow makes it 10 days. And I start work, I believe, on Wednesday, which will be about the 13th or the 14th day. And it was in recognition of the stress that we built it into our practice to have doctors after a 2-week shift at the sick office stay home. So I've heard discussions back and forth in Nigeria about hazard versus no hazard. I would encourage folks who make decisions to be mindful of the stress that this has, not just on the doctors. We actually do the least work, but talking about the nurses, the cleaners in the hospitals, those that are actually doing the work, caring for patients day to day, hour by hour, minute by minute, they should all be looked after because they're the ones really putting their lives at risk. Now, that said, I will do it again and again and again because there's a true sense of fulfillment and personal satisfaction that comes from taking care of others. You know, our practice, we're 10 physicians. One of us, actually 2 of us are hospital doctors. So 2 of us do the job that Dr. Legimet does for our group. So those 2 go to the hospital and they do the same rotations like we're doing. They don't come to our office, they don't come to the clinic. The rest 8 of us are in the clinic and we're doing the shifts between the 2 locations. But the real satisfaction is in getting that call from that 80-year-old woman who's widowed, who has COPD, who has diabetes, who has heart failure, and who is afraid that they might have COVID and they want to be tested, and you spend time talking to them. You do a telemedicine visit, we're doing a lot of that, and reassure them that you have nothing going on with you. You've not left your home in 2 weeks, just stay home. When they bring groceries for you, just leave it in the front door and pick it up 30 minutes or an hour later after spraying it. Avoid as much social contact, you know, wash your hands, and you'll be fine. We'll, you know, get your medications delivered. Just being that person who prevents that 80-year-old from leaving the house, ending up in an emergency room where most likely they'll get infected, that's the real satisfaction and fulfillment.
Great. Thank you. Thank you.
Thank you. Yeah, Professor Flying, to you.
All right. Yeah, just had to unmute my microphone. Yes. Thank you. Thank you all for your insights. I think they're very valuable. When it comes to nanotechnology, for me, the first thing that I found interesting is that viruses are on the size of nanoparticles. And in the nanotechnology field, it's actually been known for quite a while that chloroquine prevents some nanoparticles of particular sizes from entering some cells. And they're proposing that some of those mechanisms actually apply to COVID-19. So one of the things that I think might be flawed about the way the system is currently handling things is when someone tests positive, a lot of times, if there are no symptoms, it's just like, go home and wait for it to get worse. I think it would be nice if there's a scenario where once you test positive, there's immediate action that can be taken. Because based on what we're seeing from the nanotechnology studies, that some drugs can prevent nanoparticles from entering cells, it would be good to have an earlier place of attack. Now, when it comes to things like immunity or immunology, I think the biggest challenge is sometimes things are separate from health and wellness and the medical practices, right? Because a lot of times, even over here in the US, if people go to the hospital, doctors don't even say, okay, so what did you eat? Or how did you eat? So the basic things from stop smoking, eat a proper diet, exercise regularly, have a healthy weight, drink in moderation, get adequate sleep, take steps to avoid infections, those always play a strong role, and try to minimize stress. But after that, even thinking of how you eat, it looks like intermittent fasting, which was just recently published in the New England Journal of Medicine, has been very beneficial for some of the diseases that a lot of Black people suffer from disproportionately, like obesity. It improves insulin sensitivity. It seems they said it improved insulin sensitivity, or cardiovascular disease. It improved multiple indicators of cardiovascular health, or even cancer. It had some potential positive impact. So I think we need to try to take that approach of, let's hope for the best, but assume that the worst could happen. In immunology, you also have immune modulating agents you could take, but these are drugs, and drugs have side effects. And then you actually have to test it against COVID-19 to know whether it works. And there's some from in different families, and we have different drugs that could activate the immune system, but it takes a while for people to be able to develop these drugs. You asked about, and some of these immune modulating agents are even in milk that we drink. The challenge with drugs and vaccines, you asked how long it will take. Dr. Fauci from the US believes it takes 12 to 18 months, and that is a rapidly accelerated timeline, because normally some people simply explore whether something can treat a disease for 2 to 4 years. However, for COVID-19, they're accelerating the pace to try to get this done in a year and a half. And that seems like a long time, but in developing drugs and vaccines, you have to explore, then you go through a preclinical stage, then you have to submit an application to, in the US, to the Food and Drug Administration. Then you have different trials, phase 1 trials, phase 2 trials, phase 3 trials, then you get approval. And this can take a long time. And keep in mind, sometimes they're not testing these on minorities or Black people. You might not be well represented in the trials, because I analyzed all the nanotechnology drugs approved by the FDA and looked at the population of people that they tested in the trials. A lot of them will be predominantly white. So if there's a different interaction of the drug in your system, you might not even know, you just know it's FDA approved. So that's why we have to take as many proactive measures as possible. Now, you asked about Agbo and local medicine. I've always wondered about this. I've always wondered about research on what we have locally and how we can use this to better our health. There are challenges and there are potential benefits. I believe Agbo has positive properties. I believe you should drink it. Now, for it to treat a disease, I do not know, because here's the challenge with things like Agbo. When people are doing clinical trials or studies, normally we're studying one molecule or 2 molecules or a combination. Agbo is a myriad of things. It's the equivalent of, I don't know how many, but it can be more than 20 different things, and the active ingredient hasn't been isolated. For example, in chewing stick, the active ingredient is salicylic acid, which is a harsher form of aspirin. So you kind of have an idea of what's going on there. But when you have this mix of leaves and bitters and they're polyherbal, you have a complex interaction of multiple active ingredients, and you don't know if there's consistent batch-to-batch reproducibility in the production stage. So each bottle from each batch might even be different. So it might have these positive effects, but it's challenging to know for certain that it has this effect on COVID-19 or something. But I personally, if I had some yo-yo bitters or something, I would drink it because I think it has good positive effects. So I really like those things. And I think that's my general perspective on most of those questions you asked.
Thank you very much. I appreciate you all. Thank you.
Thank you. Okay, so I think let's see, in the interest of time, we're going to accelerate things. So I'll just ask some rapid questions. We have a lot of questions that have come in. I apologize if we don't get to them, but I'll try as much as possible. But let's just start off with, understanding what this COVID-19 is. I think there's still a lot of confusion. There's still people out there, they speak. Some people say it's ordinary kata. We get kata all the time in Nigeria. It's not a big deal. It doesn't have people. Heat in Nigeria will kill it. Just so many things about it. So I guess, Dr. Chooks, if you can just quickly tell us, I know you and I have had a conversation about this virus. What is it and why is it so deadly? Why are we shutting down economies because of this virus, especially when you look at the rates and you're saying, okay, people get it, some people get it mild, and they recover and then they stay home and all that. Why is the whole world just practically shut down just because of this virus? How is it different from, it's a coronavirus. I know you've told me that it's the same virus that causes the common cold, Qatar, that we know, right? So if it's Qatar, then how come, Qatar is making us shut it down? I'm trying to talk about it now from the layman's perspective, right? We have a lot of people from Nigeria here as well, so if just educate us. I know you talked this morning about, you compared it to measles and you talked about the R0 scale and all that. So if you can quickly just run us through why this is very deadly and why we should be very careful with it.
And I'll try to be very simplistic in this and use analogies to explain what I'm about to define. Why we should be worried is because this is new. We've never seen this before. It's in the same family of coronaviruses, one of which causes the common cold. It's not the same virus. So this is a new virus that was first identified in Wuhan, in the Hubei province in China in late 2019. That's how it gets the name, okay? Now, why should we be worried about it? I'm fortunate to be here in Baltimore where we have an excellent public health school attached to what I believe is the best hospital in the world, Johns Hopkins, called the Bloomberg School of Public Health. And there are two, I'll put out two definitions out there and I'll break it down, but I implore folks to try to understand it. One is called the R0, which is actually R0, and the other is called the case fatality rate. And maybe I also end by addressing the question that Dr. Honorable Dabiri asked about why are Blacks being impacted more. Now, the R0 really tells us how infective a disease is, how infective a virus is. So I used the analogy of measles. Measles is very infective. It has an R0 close to 18, which means that one person with measles can infect up to 18 persons. But the case fatality rate of measles is about 0.1 to 0.2%. Now, let's get back to the coronavirus, the new coronavirus, COVID-19, the SARS-CoV-2. Now, that has an R0 of about 2.5. So, while not as effective as measles, so one person with coronavirus can infect 2.5 persons. Its case fatality rate worldwide is now about 2.5%. And in some states, in some cities, in some localities, in some countries, it's over 10%, especially when the curve that we all talk about flattening is not flattened, and the healthcare infrastructure in your city, in your state, in your country gets overwhelmed. You can compare France and Germany, you know, countries with about the same demographics, you know, right next to each other. But in France, they have a higher case fatality rate than they have in Germany. So patients who have measles, while they might infect more persons, we don't suffer as much mortality. However, patients who have the coronavirus, COVID-19, they might infect less persons, okay? But because it's a new virus and we don't really understand the pathophysiology and the way the disease progresses, we're finding that the case fatality rate can be as high as more than 10% in some places, like in Italy. So that's why it's important to practice the best treatment, in my opinion, which is prevention. We definitely do not have the infrastructure in Nigeria to acutely care for patients with moderate or severe COVID-19 disease. So our best use of resources is to test often, track patients and their contacts, and offer supportive care to the few if we can flatten the curve. As a country, we do not have the resource to be able to treat patients if they pour into our hospitals in the numbers that we've had in New York City or in Italy. Now back to the question about disparities.
Yes, ma'am. I just wanted to tell you your video is still on, just so you know.
Back to the questions about disparities, disparities in care. You know, while not getting into any discussions about you know, politics, what's right or wrong, if healthcare is a right or if it's a privilege, you know, why not get into any discussions about, you know, who should get what, you know, right or left. Healthcare is expensive, period. Don't let anybody tell you otherwise. It's expensive here in the United States, it's expensive in Europe, it's expensive in Nigeria. And disparities also exist everywhere. Here in the United States, in Baltimore, in Europe, in France, and also in Nigeria. The problem we're facing here, and I believe Professor Robobo kind of addressed it, and I liked his statement about doctors not telling folks how to prevent illness, not asking people, what are you eating? What are you drinking? What are you smoking? You know, why are you this fat? You know, that unfortunately is the problem we face in our population, our community, is a high prevalence of illnesses like hypertension and diabetes that lead in the long run to coexisting illnesses, heart disease, kidney disease, that when a virus like the COVID-19 comes into play, then it overwhelms the body. Unfortunately, when you compound that with socioeconomic disparities like you have in Baltimore City, You might have the best hospital in the world right in your neighborhood, but you don't have access to it. It's not available to you. And if you have both, you can't afford it. So that's really what's going on, and it explains the disparities here.
Okay, thank you, Dr. Chooks. So real fast, trying to speed things up, interest of time. Well, lots of questions, like I said. So we'll jump to Dr. Uche. Dr. Uche, we have a lot of questions from Nigeria, so I'll just try to lump as many as possible into them. People are asking about, I mean, guess, you know, is the virus going to impact Nigeria just like the rest of the world? Are Africans immune from the system? Does it make sense to have shut down the Nigerian economy when we don't have that many cases? Are we just copying what the Western world is doing and not taking into account, you know, what the peculiarities of our own environment? Wouldn't it have made more sense to just isolate those that are more at risk and let the rest of the Nigerian society run? How are the funds that are being contributed being distributed? So if you can just quickly just run us through, you know, what your own thoughts are, what your experiences are in terms of, you know, the virus's impact and then the operational side as well.
Right, and again, you know, Honorable Abike asked a second question, which I chose to defer because of the time, and that question has come up again right now, which is what the outlook is going to be for Nigeria.
Right.
So in answering that question, I'm going to hopefully answer a number of the questions you've lumped together. Now, there's something we don't want. We don't want a community spread. We don't want community outbreak in Nigeria. You don't want to have to deal with that kind of thing right now. All you have to do is take a look at what's going on in countries where they have much better capacity to cope than we do. And then you see what's happening there. And then you want to understand why the authorities will do everything possible to stop community spread. It is brutal, it is painful. We're all paying the price. I'm not saying all the right things are being done. There's a whole lot more that could be done. But I can understand why there has to be a restriction to movements. I can understand why there has to be social distancing. You know, the economy is not totally shut down, but I also have in mind that there are people who literally live from hand to mouth, who earn daily income, and this is how they survive, this is how they pay their bills, this is how they feed their families. And then such individuals you know, are having to pay a bigger price at this time. That's understandable. I'm aware that government is making certain efforts, but it's also very likely that it's not getting to everybody who needs the support at this time. But I'll encourage everyone to just be patient. I'm in a lockdown myself. I'm in my home at this time. Let's all be patient. I'll encourage people to reach out to one another, whatever assistance you can give. I am hopeful that if we keep going in the direction that we're going, we are not going to have the kind of outbreak that I'm afraid of. Again, look, there are a few challenges here. Today, I cannot tell you that we know exactly how many people are infected in Nigeria. There is a testing capacity, a declared testing capacity of 2,500, okay? Out of 200 million people, you test 2,500 a day. Now, altogether, today we've tested less than 8,000 people since the outbreak started. So what that tells you is that it's very likely that there are people who are infected, who are in society somewhere. And except you restrict these people, and maybe they develop strong symptoms and they're taken in for treatment, they're going to mingle with everyone else. And then this thing is going to spread, and we can't deal with that. So it's important that we restrict our movements at this time to whatever extent that it still allows us to live. Okay. So what's the next question, Obina?
Yeah, so I guess the questions, you know, around, so when you say, so when you talk about the severity of the issue, like for a lot of people, right? the challenge with it's not that easy to just stay home. We like have day-to-day needs and all that, right? So, but when you say that that the impact is going to be very severe, you know, can you explain more on that? I think people just don't really understand what this virus can do, right? So even if you just say stay at home, I mean, what does that mean? If somebody has to go out and eat, and then, you know, are there other things that people can do as well, right? That can help,
Yeah.
you know, take into consideration some of the things that they have to do to survive, and at the same time keep themselves safe. Right?
Right. So it's impossible to sort of bring out all the possible scenarios. That's not possible at all. But I can tell you something, and maybe it's in the way we are communicating. Maybe we're not communicating effectively to the people who need to hear us. Look at it this way, right? If people feel that they're being restricted, that the government is not letting them move around, then they're going to feel caged. Then they're going to wait to be told, it's okay, you may now go out. But if people understood why they're being asked to stay home, they on their own will figure out what to do in order to avoid exposure. This is the point. So maybe we need to find a way to communicate so that if you were to tell people, I leave it to you to go out or not, I leave it to you to mingle or not, they would choose to keep to themselves. They would choose to stay at home. So that's one. And then today, when Kelechi talked about isolation, I said that today we are not able to ask people to be treated in their homes, observe in their homes when they have tested positive, or go to any hospital and see a doctor. That's because the healthcare infrastructure in Nigeria cannot cope with that. Our lifestyles here cannot cope with that. But if we mingle without restraint, the tendency is that there will be community outbreak. It kills Blacks, it kills Nigerians. Somebody sent me a video just some days ago of Nigerians, young, middle-aged Nigerians who have died in places where there's been community spread. So if that happens, there's no reason why such individuals will still not die here. So again, I'll take the opportunity to encourage everybody to bear the discomfort for this period, and hopefully we'll pull through this together.
Okay, so some more questions. You know, you're talking about the coordinating with the private sector. So a question came in where someone said, "How can I get more PPE, which is protection equipment for staff?" Is that something you handle as well, like working with the hospitals to get resources or people that need them?
Oh yeah. So if you listen, for example, the story about surgical mask, okay. Everyone should just understand that we don't know too much about this virus yet. We're all learning. After this outbreak, we're going to do the postmortem, we're going to understand it better. But those people on the front line, those people at the treatment centers, they will always need the PPE. You can imagine how many people go into a treatment center every day. Each time they go in, they have to don their PPE, doff it, discard it, and they have to go in again. So yes, people need a lot of PPE. People who work in other hospitals, who see patients who we don't know what they have, because this virus is treacherous, okay? People could carry it without showing any symptoms. So those doctors should always be protected. They should wear some decent PPE, at least the facial mask or something. Now, are they available? I can tell you today, yes, there are sources as far as I know. I am not aware that the challenge has been that they can't be found. They can be found. And so if the resources are deployed properly, there should be adequate PPE for those who need it.
Okay. So one last one. So in terms of your coordination with the private sector on this, so there's a question here around all the funds that have been donated, right? How are those funds being managed? How have they been managed, or how they plan to be managed? Is that something you are aware of, or you participate in as well?
So I'm not directly involved in, I think I saw a list of the big donations by well-meaning Nigerians, you know, that amounts to some billions of naira. Now, I'm not involved in how that is disbursed, but I'm involved in the people I'm in contact with, I'm involved in holding their hands and guiding them and interacting with the people who actually get the work done, and ensuring that the resources they put at our disposal are utilized in a way that first addresses the concern, makes them feel like it's been judiciously utilized in a way that is sustainable, and in a way that we can account for. So that's what we know.
Okay, yeah. Okay, thank you, Dr. Uche. Dr. Kelechi, I'll jump to you. You know, there are lots of questions here around, you know, COVID-19 and protection. How do you protect yourself the best way? So I think since you deal with the patients, I mean, directly, I think maybe you're best to answer these, right? So if you can just walk us through quickly on how best to protect oneself, right? We see all these videos, now, like out here, there's a shortage of masks. You can't even find masks to buy. There's no sanitizer and all that. And if we take that back to our own environment, people are talking about masks that used to be, you know, 300 naira is now going for a pack, is now going for 10,000, 15,000 in Lagos. So what are the best ways that people can protect? And then other questions are coming, like if somebody has like the virus today is infected and they recover, can they get reinfected again, or do they build immunity?
Okay, I'll start with how I protect myself. So prior to coronavirus, I used to dress up to go to work, okay? I used to go with my long hair, my clothes and everything to work, and I don't do that anymore. We are scaled down to minimal stuff. I wear scrubs to work. I wear sneakers to work. The hair is gone. For a hospital, they made the men shave their beards. So it's bare minimum. So you try not to take a lot of your personal item to work. Coming back home, just like Dr. Abel said, there's a lot of information out there. First of all, we're finding out the virus will stay on your mask. The virus stays on your clothes. And then last week, they now said the virus stays on your sneakers. So it's now a question of like, what do you really wear to work, and then what do you bring into your home? So like Abel does, he strips down in his basement and he goes take a shower. A lot of people don't have basements. A lot of people don't have all of that. And then some people live with their families. They try not to contact their families until they strip. I live alone. So everyone has a different routine. Some people wear their street clothes to work, change to their scrubs in the hospital. When they're done, they bag their scrubs and their shoes. They don't take them home, they leave it behind with their ward coat, and then they go back into their street clothes and come back in. I don't do that. I wear my scrubs and my sneakers out of the house. I come in, I have a little pan that has water and bleach, and I leave my sneakers in there. I go straight, I take off my scrubs, I put it straight into the dryer, and I head straight to the shower. So that's what I do in terms of my daily wear, and I do that on a daily basis. In terms of PPE, I think every hospital has tried to provide PPE to their patients. Various people have different things, but the ideal thing is that if you're in direct contact with a patient that has COVID, you should have an N95. If you're basically quarantining, staying at home, the recommendation now is everybody should wear a mask. I think that's pretty much how you can protect yourself. You should continue with the social distancing. You should continue with your sanitizer. If you don't have sanitizers, you can use wipes. I use wipes. I prefer wipes because I can get underneath my nails and scrub my nails. But those things are for when you don't have water and soap. The ultimate thing is water and soap. So for example, in the hospital, even before COVID, we wash our hands after every patient encounter. I see anything from 20, sometimes 22, 23 patients every single day. I wash my hands in between patients, after patients. I mean, I wash my hands probably 30 or 40 times a day. So washing hands is not new to us, but maybe for the general public, possibly. But those are the things you can do in terms of taking those precautions to, you know, not make yourself contagious. What was the other question you asked?
I was asking, the best way. So like where you have situations where people can't get the masks and things like that, right? So what are the best ways people can do that? You talked about
Yeah,
soap and bleach, right?
the mask
What is
is
it? How do you
difficult.
make a good mask?
Oh, I think there's a video by the Surgeon General to make a mask. I think there's a video out there. And I watched the video, but I didn't try to make one because I have one. The only thing I can say is I'm able to use the mask unlike before where you can use the mask and you toss it. You can use a mask every day. You can use the same mask over and over again. What they're also doing here is they're showing you how to preserve your mask, how to wipe it down. Some people use hydrogen peroxide, some people use different things, but you wipe your mask down, leave it to air dry and use it again. The mask is actually better when you're in public. In your house, you don't have to wear a mask, but in public, go ahead and wear the mask. Some people use bandanas, some people use scarves. They're all recommendations. Anything you can use just to cover your nose, your face, just to prevent contact with somebody else is always considered helpful.
Okay. All right. Yeah, thank you. Okay, so Dr. Chooks, we'll jump to you right now. So we'll talk a little bit about the virus itself, right? So there are questions here around, the virus mutating. We've heard about the virus, taking different forms. Every day there's something new coming up. So if you just talk a little bit about that from what you're seeing, and also talk about this issue about the prevalence being a lot higher within Black people, one of the things I get, we had that conversation is if it's more prevalent around Black people, then Africa is all Black, Nigeria is all Black. So does that put us in a very precarious situation? Or is it something where, the heat there or the environment or something is going to protect us a little bit? Because, if you're seeing the Black population here having higher numbers, then Africa is all Black, and, potentially you would expect that it could be devastating over there.
Great question, but I must clarify that I don't think the increased morbidity, increased illness in the Black population in, I can use the data I have in front of me here in the state of Maryland, is because of the Black person just being Black. So we cannot translate that to say, okay, then we're going to get worse in Africa. And if we don't have it worse in Africa, why? I think it all ties down to the socioeconomic factors and disparities that have existed before COVID-19. The analogy I use is, if you remember Katrina and the Hurricane Katrina in New Orleans, it hit folks, I believe, in the place called Ward 9, the lower wards, a lot more than folks who had more resources, who were richer, had better housing, had better access to care. So most of these Blacks that have been affected here, and I'll try to use an analogy as to what might happen in Nigeria if we don't do what we're supposed to do properly now, which is distance ourselves or distance ourselves from others, is if you have a city like Baltimore, predominantly Black, and they're the ones who are the bus drivers. They're the ones who are the cleaners. They're the ones who are the grocery store clerks. They're the ones working at fast food. They're the ones actually in the front line. They're the ones, the critical care workers. They're the blue collar workers. That's a term we use here a lot. They're not the white collar workers, the folks who wear the suit and tie and work from home on a computer. So when the country or the state shuts down, they're home. But the bus driver still has to go to work and transport folks. And I've seen the same data reproduced in the UK amongst bus drivers. They're the folks cleaning the hospitals. So when there's a shortage of PPE, you can imagine most likely the doctors will get priority, right? But the cleaners might not have as much access to the PPE as the doctors. So now these disparities exist in Nigeria. I don't want us to think they don't exist. They exist between the North and the South. There's an obvious disparity in socioeconomic status in some parts of the North and some parts of the South. There's some obvious disparity in access and availability of healthcare resources between the cities and the rural areas. So let's not kid ourselves that it's only in America, it's only in Baltimore, it's only in the United Kingdom, it's only in London. No, if we don't do the needful now and distance ourselves and prevent it from getting into the community, like I believe another panelist mentioned, if we don't try our best to avoid community spread, we will have a bigger problem on our hands, and that's when we'll really have difficulty reining in this disease. I went to University of Benin. I picture a Selu market. I picture a new Benin market, you know. Currently, it appears most of the disease in Nigeria was brought in by folks who traveled from outside and returned, who traveled and returned to Nigeria with disease from outside. Let's keep it there. Let's isolate those people and prevent community spread. Let's prevent it from getting to that market woman in the Selu market, that market woman at the new Benin market. Let's prevent that, because when that happens, the disparities that were laid bare by Hurricane Katrina in Nigeria will be laid bare for all to see, and it will not be a pretty sight.
Okay, all right. Thank you, Dr. Chooks, for that. Dr. Uche, I want to come back to you just quickly, right? So, you know, we've talked about, you know, potentially what Nigerians need to be doing. But I mean, for the average Nigerian, you know, there's some level of shutdown. Well, Lagos primarily and Abuja, those are biggest cities. And, you know, some questions have come in now. I started talking about, okay, what about after all this, right? What can people expect life to be like after all this? How do you, as an employer, work out how to go back, you know, get your business started again? How do you stop your employees from getting infected? What is life going to look like, you know, in Nigeria? In the US here, we're still trying to figure that out, but a lot of questions around that in for Nigeria. So if you can talk, I know you talked about, you know, you're working with organizations to implement business continuity plans. So if you can talk a little bit about what you think or how people should start organizing themselves for after all this ends.
Right. What I know for sure is that things are not going to be the same. It's just not possible for for us to say, okay, now it's over, let's go back to doing the same old things we used to do, the same way we used to do them. That just won't happen. Okay, now when businesses go down, you don't turn on the switch and then they come back on. They come up gradually. Okay, and some businesses, unfortunately, may not be able to come back. They may not become relevant anymore in the post-COVID-19 Nigeria, for example. So we don't know for sure. Nobody's able to say, but this is the time for people who do business to reflect on their own and think about what I'm doing. Am I still going to be able to do the same thing? Do I need to do something differently? The people who I employ, for example, do I still need that many? Otherwise, or do I need more? You just never know, right? So that's all part of business continuity, and it just doesn't depend on one particular individual. The systems are all interconnected. So the decision you take about your business would impact what happens with my business. So I think, first of all, we should just brace for a major change in the way we think, in the way we do things, and then take it one day at a time. As they say, you know, you have a plan. If you get into the ring, you have a plan, and then until the first punch lands, and then you realize that your plan just doesn't work the way you thought, and then you have to plan according to reality.
Wow, okay. Thanks for that. Professor Ogo, I want to jump to you and talk about ventilators. Lots of questions too around ventilators. If you can just explain to us why the ventilators are important. I know you talked about Ethiopia doing some things with ventilators. Someone asked about, some Africans who have, either designed or produced low-cost ventilators and saying, how rapidly can they be put in service, especially when you see that somewhere like Nigeria doesn't have that many ventilators. Are you on, Prof?
He's muted. So
yeah. Okay.
Yes, hello.
Oh, okay.
yes, yeah.
Yes. Did you hear the question?
Oh, sorry, could you please repeat the question?
Yeah, so the question's around ventilators.
Okay.
Why the ventilators and ventilators important? We hear all this time, shortage of ventilators. Why are they important? And you talked about Ethiopia, doing some stuff with ventilators, and you've also been doing some research into them. Someone
Yes.
talked about, Africans have produced ventilators, right? And how quickly can they be developed to standard, and can they be used in Africa or Nigeria?
That's a very good question. So I think the first challenge, which might even be more important than ventilators later on, actually, sorry, let me start with why you need ventilators. You need ventilators for probably the severe cases, as Dr. Kelechukwu was talking about, right? The severe cases, when it's gotten to the point that you have COVID-19 pneumonia, right? And that's the standard approach. So someone asked, why do people on ventilators die? That's the standard approach, to ventilate patients and try to maintain high oxygen levels until their lungs are able to function in a normal way again as they recover. Now, there are about 77,000 new ventilators to meet the entire market demand globally, right, last year. And then New York alone needed 30,000 additional machines just now. And when you start thinking of the ventilator manufacturers, they boosted their production, but they can boost it by maybe 30 to 50%. They can't deliver the 500 to 100% growth that is required immediately. So when you say places like Ethiopia, Ethiopia had about 90, when I last checked, it was 92 confirmed cases, 3 deaths, and 14 recovered cases of COVID-19. They expect the COVID-19 cases to continually increase. And who is advising African countries to mobilize ventilators for people that have this severe cases towards the end? Ventilators are not typically manufactured locally in a lot of places in Africa. So governments have been assessing avenues to see how they can overcome that challenge of scarcity of medical equipment, especially the ventilators. So this huge gap, we're hoping, okay, for Ethiopia, I think their population is smaller than Nigeria. They're the second largest country. They have 109 million or 110 million people. They have about 450 functional ventilators and 197 non-functional ventilators that require maintenance. I think these numbers are still higher than Nigeria's numbers. So without the adequate supply, doctors are going to be faced with life or death decisions on who needs the ventilator the most to continue breathing. Now, keep in mind, ventilator shortage had been an issue in Africa before COVID-19. So when you say ventilators, it sounds very ominous. We almost even want to make sure we don't get to that point. What the world has done, which has been fantastic, is they've come together. Medtronic, a big medical device company here, they have listed their device open source. You could go see all their designs, all the electrical components, everything. However, when you assess the buildability is, it's hard to do. They have a very advanced ventilator, but they're not the only ones out there. There are probably at least 100 different ones, and I have a list for those that are interested. So when you're talking about the people in Nigeria, how are they going to test the reliability testing? So if you're talking about building a cheap ventilator, for example, a ventilator testing system, the one that we are going to be using, is at least $10,000. So some people are trying to build $100 ventilators, $250 ventilators. The US even put out a call for a proposal that if you can build a $4,000 ventilator, you could get a large sum of money to work on this kind of project. You need to be able to build $4,000 ventilators and be able to supply, I can't remember the exact number, but I think it was in the thousands. So the reliability testing now comes into question for some of these open source designs. So some Nigerians are very talented at programming. So you can go get an Arduino and take your Arduino, get some tubes, and say you can have a particular pressure difference and deliver volumes of air. But you need high oxygen levels. So an oxygen concentrator to get oxygen out of the air is probably one of the more important aspects of what we need to address. So that ventilator issue, think about it, severe stage. That's why we need the ventilators. People are going to have such bad scenarios with COVID-19 that they need it. So that's the first thing they need to think of. But in addition to ventilators, don't just think of it as something that needs to be built. You need oxygen concentrators as well simultaneously to be able to try to address that issue. I think the term used was hypoxia by Dr. Olejame, and you have low oxygen. You can't just be breathing the same concentration of oxygen in air and expecting to have a positive effect. So that's kind of how I'm looking at it holistically from there. So that's one of the reasons why we're trying to make sure there's more reliability testing of ventilators, so that if one open source design is tested, at least you're able to recommend, hey, team A in Ethiopia or team A in Nigeria, build this one. Because right now the reliability testing is 0 on some of them. So that's a very important aspect.
Okay, cool. Yeah, thank you, Prof. Just getting to the end of this, but I have to ask this question that just came in. I think it's a pretty interesting question. Dr. Chooks, I'll leave this for you. So someone said, if we can just wash this virus off our hands with soap and water, why can't we just wash it off our nose and lungs with soap and water as well?
Okay. Nice.
Very good question. Yeah.
What's that?
No, very good question.
Exactly.
The difference is mucous membranes. That's the difference. So throughout this whole session, I've been touching my beard and my face, and you're advised not to do that because the potential of using your infected hand to touch your face and come in contact with mucous membranes, that either your eyes or your nose or in your mouth, that leads to direct access to the virus to get into your body and attach itself. Because a virus on any surface, depending on the surface and depending on the time, will die. But once it attaches to your mucous membrane and has the ability to incorporate itself into your body, then the battle is lost. So the key is distance yourself from people who are sick, stay home, and when you do have contact with potential contaminated surfaces, and assume everybody else has it, wash your hands for 20 seconds with soap and water. And like Dr. Olejame says, we actually prefer to wash our hands with soap and water than to use sanitizers. And you're fine. And do that very often. But once it gets in contact with mucous membranes, it's too late.
Okay. Yeah, Dr. Chooks, thank you for that. I'm good. It was good to know. So, Honorable, there's a question here before we continue. There's a question here for you. I don't know if you want to take questions, but someone's just asking about the process for evacuating Nigerians in the diaspora back to Nigeria. You're on mute.
Let me
okay.
Am I?
Yeah, you're good.
Yes, go ahead.
Yes,
Am I
you're
good now? Okay,
Yeah.
great.
Yes.
Now the process for evacuating Nigerians is a bit harsher, but here is it. The NCDC protocol says, first, we want you to be tested in your countries of departure. Now, in West African, like in Togo, we have 24 that were already tested in Togo, and they are already in Nigeria, they're in Lagos, and they're already on quarantine. And 23 of them were negative. One was positive. The positive one has been a quarantine. I don't know whether it's quarantine or isolation. My sister corrected me in Togo. Now, when they got to Lagos and they were in isolation or quarantine, after NCDC tested them, one of them was positive. So out of those 22 that came, because one was positive, all of them must stay for 14 days. Now, here's the thing. If you're coming from the US or UK or anywhere, what we're saying is, number one, test yourselves in those countries of departure. In Dubai, UAE, it's okay. You walk into anywhere, you get your test. In fact, they can test you before boarding. So we're hoping that those in Dubai, UAE, will be tested before boarding. And when they come in, NCDC will still test them. And after testing them, NCDC will decide, oh, you're negative, stay for 2 days or go, depending on when the results come. Now, in the UK, for instance, NHS testing is difficult. It's free, but it's difficult. But you can do private testing. Some have done their test. Out of those who have done their test, from what we're hearing, some were positive. And they've been told to go and self-isolate, or is it quarantine? And thank God for that test. Yeah. They are already in self-isolation. And they've told all those who met them to go and do the same thing, go and self-isolate for 14 days. They've saved about 9-10 people from themselves. Now in China, walk in and get your test done is not a problem. So what in the USA is virtually impossible. Even USA is not enough and you can't do private testing. So what the Minister of Foreign Affairs has said is we'll do it in batches. So for the first set that we get, you're able to do your test, you come in, you also go on self-isolation compulsory in a hotel. NCDC will decide as you have advised. However, if you are positive, what happens? It doesn't mean you will come to your country. No, but it means that they know your status and can arrange for you properly. Like those in the UK that have tested and are positive, they're already getting treatments, they're in self-isolation, and they've saved their relatives from themselves. So in doing this, you know, my sister said something, when you were talking, you said nobody's flying. Yeah, nobody's flying, but Nigerians stranded and saying we want to come back home. Now, they are not Nigerians living abroad. They are Nigerians went for vacation, holiday, horses, business, and got stranded. So do you leave them out there forever? So it's a catch-22 situation. We need to be strict with our protocols by NCDC, but at the same time, you want them home. So what the Minister of Foreign Affairs is saying is, let's work on the logistics back home. When you come back and we're saying self-isolate, where do you go to? The hotel, everything or whatever you suggest has to be put in place. So let them understand that. And I think we want it to be a win-win situation for everybody. Everybody. I hope that explains what the answer.
Yes, and the process for anybody who wants to, I know I've seen some information, for anybody who wants to come back home, I know there's a form that they go to the website to fill out.
No, yes, it varies from country to country. UAE, they fill out forms. And can I tell you something? In New York alone, there are over, I think, over 500. In Dubai, a high number. In China, a very high number. In the USA, a very high number, between 500 and 700. Fill the form, go to the mission. And some say they can't get the mission, but you can get the Ministry of Foreign Affairs. So whatever the case, if there's update from the Minister of Foreign Affairs, I hope next week, everybody that has filled will be communicated with. That is what we can guarantee you. And the countries likely now will be China, UAE, UK. USA is a problem because it's difficult to do your test. But understand one thing, you get on a 10-hour flight without knowing your status is a problem to you and to everybody on that flight. That's what we're saying. So in the USA, if it's difficult to do your test, what do we do? So for those UAE, before you even board, you do your test. So if you're negative, if you're positive, they will put you somewhere and you get your self-quarantine or self-isolation or whatever medical term. In the UK, quite a number have done their test, and if they are positive before the flight comes, they may be negative. So what one Nigerians to understand is that is a catch-22 situation. Let's protect everybody, even the loved ones you are coming to meet to be protected. So by next week, the Honorable Minister of Foreign Affairs will give us more directives and will also relate them to every Nigerian who has been stranded. But over almost 3,000 now have been stranded and want to come back home.
All right. Thank you, Honorable, for that. So just at the tail end of this, and wrap up pretty quick. So, Dr. Uche, I want to come back to you quickly before we wrap up. Just, of course, the chloroquine conversation, right? So lots of questions on that, about how we can, Nigeria should tap into that, do our research. We have Abo, we have quinine, we have the Goyaro. Just from your own experience and from what you're seeing on ground, and from your professional experience as well, can you just give us some insight into chloroquine being effective and all these other home remedies? Like someone asked, this basically mean effective against the virus. People are talking about turmeric and ginger, all that. So especially for Nigeria, where there's a lack of information, a lot of misinformation going around. If you can just give us some clarity around these remedies and chloroquine itself.
There's a lot of research going on. There's a lot of work going on. There's a lot of research going on about drug treatment, about vaccines. This virus, we don't understand it very much yet. It was actually called the new coronavirus, okay, until the name changed to COVID-19. About chloroquine specifically, people confuse chloroquine with quinine, all the quin. They think it's the same thing because they're both bitter to taste, but they are not the same thing. Chloroquine is an anti-malarial as we know it here. Over the years, there's a lot of chloroquine-resistant malaria. So today, it's not even a very popular anti-malarial agent in Nigeria. Now, the use of chloroquine to treat COVID-19 is a research that has been done. It looks promising, but we have to acknowledge that there is a process. There is a process before you can say that a particular medication is used to treat a certain condition. There are guidelines that must be followed. I am aware that there is a World Health Organization protocol that you can deploy, you can activate it to bypass some of those steps. It's an emergency protocol for the use of investigative medicine, as it's called. Now, they will do that when they think that the matter is so urgent, so many people are dying, and there is no other way, and this medicine is promising, then they will activate that protocol. And when you do that, you have to get patients who will consent, who will sign volumes of papers before you can use it on them. So it's not that straightforward. I have to say, though, that it wouldn't surprise me if some doctor quietly agrees with his patient and says, look, it's chloroquine, it's not going to kill you, you better take it and survive. And that happens, and there's nothing anybody can do to stop that. The officially claimed treatment, it has to go through certain processes. And that takes time.
Okay. And so what about other remedies?
Sorry, can I
finish
up? I was going to add to that.
No, go ahead.
Or do you want to ask your question about the remedies?
No, you go ahead. Go ahead.
Okay, so let me answer this question about the chloroquine. So first and foremost, chloroquine is an antiparasital. It's a medication that treats antiparasites. It treats parasites. COVID virus is a virus infection. The mechanism of action for which chloroquine treats malaria is very different from the same way it helps. Anecdotally, it's not even proven with the COVID virus. And I think what I want everyone here to at least take away is my understanding of treating chloroquine when I was in Nigeria was you either get an injection or you get a tablet and then you take it every day for like 3 or 4 days. And I think people feel that that's the way this is being done. It's not the same way. First and foremost, there's a treatment algorithm for COVID virus. Based on whether you're mild, moderate, severe, there are different medications available for you. A patient doesn't come in, get chloroquine, and then that's all the other thing we give them, and we send them home. I have never used chloroquine for a COVID patient in the US. What we use is hydroxychloroquine, which is called Plaquenil. Now, what COVID also does is, first of all, it makes your oxygen low. So we target that, we give you oxygen. It makes people have blood clots. We target that, we give you a blood thinning medicine. It makes your lungs shut down and clamp down. We target that. We give you medications for your lungs that would open up your lungs, okay? It also makes your lungs fill with fluid. We target that. We give you medications to try to get you fluid off your lungs. It causes you to have a pneumonia. We target that. We give you an antibiotic. If your liver fails, if your kidney fails, you're put on dialysis. If your lung fails, you're put on a ventilator. If your blood pressure goes down, we give you what is called pressors to pull up your blood pressure. So the treatment of COVID is not take chloroquine 3 or 4 times a day, drink 2 tablets and go home. It's very, very, very complex treatment. So, and then at the end of the day, one of the side effects of the chloroquine is that it affects your heart and it makes your heart have heart arrhythmias. If you already have a bad heart, chloroquine is not for you, or hydrochloroquine is not for you, so you don't get an option to use that drug. If we actually give you hydroxychloroquine, we put you on a telemetry monitor and we monitor your heart. So it's a lot more complex than chloroquine and take it down and take it home. What they're thinking about, the way it works, just like Dr. Erobo was said, is the coronavirus has protein spikes. And what they think is those protein spikes attached to your mucosa. What hydroxychloroquine does is it creates an environment that makes coronavirus not want to attach to your mucosa, which is different from the way it handles malaria. Malaria is reproduced in the red blood cells, and chloroquine targets the red blood cells to stop the malaria parasite from replicating in the red blood cells. So there are 2 different mechanisms for which chloroquine treats malaria and for which either chloroquine or hydroxychloroquine is thought, not proven, but thought to use to treat COVID. Now, there are studies here that, the studies that come out at samples, there are 30 people here, 50 people here that come out back and forth and say that it's good. The first study came out from France, I believe, that said hydroxychloroquine or chloroquine was good and everybody jumped on it. However, we have new studies coming out saying that it's not good. So there's a 50-50, does it work or not? And I'm not sure if you're aware, yesterday there was a viral medication that came out. It was another study from Chicago that had treated 130 patients that were on the ICU, and apparently the viral medication seemed to work. So people are now almost running away from hydroxychloroquine and they're now going towards that virus. Now, there are other studies as well. There's also plasma transplant. There's also anti-immune agents. Everybody is throwing whatever they can at this COVID to see which one will stick and just to make the patient survive. So I don't want anyone to think it's as simple as, okay, take chloroquine 2 times a day for 5 days and I'm cured. It doesn't really work like that. And apart from that, even though COVID is very mortal, 80% of the patients that get COVID will get well. With or without any medication, they will get well. So the question is, if they were destined to get well and you gave them hydroxychloroquine, would they have gotten well without the hydroxychloroquine? That is studies that people have to do, and we don't know the answer yet. So it's a lot going on. This scenario, this data changes every day. And I'm telling you, every week is a new information. So we're really, really all learning. But I just want to make sure that it's not, people don't think it's like malaria, take it 5 days and go home and you're done. It's not as easy as that.
Wow. Okay.
Thank you, Kelechi.
Sorry.
all the sickness that you just mentioned, man. I don't, well, I guess the summary is just don't get sick. I think that's the general advice. Try as hard as possible not to get sick. So anyway, so we've gone on pretty long with this pretty engaging conversation here. So I just want to try and wrap this up. So I'll just give each of the panelists maybe a few seconds just to summarize what they're saying and general advice.
Sorry, just a moment. Before we round up, can I just make a final moment? And I just want 30 seconds from the panelists because I also got questions coming in, and it's not a question really. Just 2 quick roundups, and I plead with you now. Awareness, what are we doing wrong? And what should we do? It's about awareness now. What do you tell the people? Why do you tell them don't go to the streets? I know you're earning money daily, but you're not. What do you do? And then secondly, Melinda Gates made a statement, very depressing statement. She said, in the next couple of months, Africans will be falling on the streets and dying. Do you agree with that? Yes or no, and what do we do? Those are my two final words for you. And to say thank you so much. I've learned more than I've ever learned about COVID-19 from all five of you, including Obina. And I thank you for putting this together. If anything I've learned about COVID-19, like I tell you, and I mean that sincerely, it's been more from this program than ever before. And I stood all the way through to be with you. And I'm sure every other person has learned from your discussions. And I'm going to follow up with all of you individually, collectively. Thank you very much, and God bless you all.
Thank you too.
Thank you, Honorable. So we'll start off with Dr. Uche, since you're in Nigeria, let's start off with you. What should, in terms of awareness, what should we be doing, or what should Nigeria be doing?
Initially, I saw a lot of traditional things, print flyers, make jingles in the major languages, and hope that it resonates with the people. Now, I am not sure that works. Initially, I actually said, maybe there is something we're not doing right. Maybe we're not getting across to the people. Maybe we are not making people understand that they really need to stay at home, not because we want to restrict their movement, but because given the choice, they should want to stay at home. So I'm thinking that we should, I'm not a communication expert, but we need to engage with communication experts and tell them to figure out how do you communicate to the unique people of Nigeria. There are various, strata in society, and you communicate differently to each stratum. And how do you communicate to them so it gets across to them, so that when government says stay at home, they understand it's for their safety, it's for the safety of their loved ones. And if they were told, look, there's no policeman on the way to stop you, nobody, they will prefer to stay at home because they understand that they are safer, their loved ones are safer. And even if they wish they could go and buy food, but they really don't want to do that because they have weighed their risk and it's safer to stay home. So I think we need to engage with communication experts and tell them that this is where we want to be. Maybe we'll make a headway in that direction.
Thank you.
Okay. All right. So for the next question, I think the second question, Honorable, was the Melinda Gates statement that there will be millions of bodies in Africa. So do you agree with that?
On the streets, dying.
Yeah.
Is it possible? It's possible. Again, we said we don't want an outbreak here. Okay. I saw some videos out of Ecuador where people die and their bodies are left in their living room for up to 4 days because there are so many dead bodies to be picked up. Now, if we get into an outbreak situation here, we're not like Wuhan. We can't build a 2,000 capacity hospital, 2,000 bed hospital in 6 days or 10 days as they did. We can't do that. We don't have the ventilators. And in any case, the clinicians will tell us, most of the people, majority of them who get to the point where they have to need a ventilator, more than half of them don't make it, right? And we're told that the longer you stay on the ventilator, the worse your chances of surviving. We're told all of that. So we want to do everything possible to prevent an outbreak, because if there is an outbreak, you don't want to imagine it. A lot could happen, okay? It is a picture you don't want to paint in your mind. And we should do everything possible, everything, every one of us, to stop us from getting to that point.
All right, thank you, Dr. Uche. Dr. Chooks, I'll jump to you quickly. So for the question, there are two parts to it, at least for me. One, in terms of what should we be doing, answering from what should Nigeria be doing and what should the diaspora also, because I also think that, the diaspora here, there's not a collective effort, even in terms of awareness, right? And we're starting to see even Nigerians in the diaspora succumbing to this as well. I just heard of two people, one of them that I know, that passed away from COVID-19 in New York and Detroit this week. So I think the diaspora can do better as well in informing and educating ourselves. So.
Yes, I'll be quick. Number one, with regards to what be done at home by government, religious organizations, civil society, and businesses. And it should not all be the task of government. That's the truth. We have to, as the panelist, Dr. Korocha said, communicate better to our people and explain why. That's what you have to do. But while doing that, you also have to understand the peculiarities of our society and make accommodations that make that self-distancing practical. That is the heavy lift. You know, I know particularly, my mother is in Asaba right now, and she told me that they set up a market in an arcade where they did practice some distancing, which was outside the crowded market, and folks could go and stay a little bit, 6 feet, 1 meter apart. That's an attempt. And, you know, we can put our best foot forward. Now, Bill and Melinda Gates, they know a lot about Africa. And they know a lot about health. And if they say something, I believe government should take them very seriously. However, they're sounding the forewarning now because this is the time. We have to proactively do what we need to do to prevent bodies from lining our streets. This is the time. We still have the window. I would like to discuss, but we don't have the time, the difference between Germany and France. I will share an article with you, Honorable Dabiri.
Yes.
They both had cases about the same time, their first cases. But France has 12,000 deaths, Germany has 4,000. The difference is simple. You have to test, test, test. And once you do that, you have to track the folks who have tested positive and isolate them to prevent a community spread. Once you have a community spread, I'm sorry, the horse is out of the barn. That's what we cannot afford to, because we cannot build the hospitals, we cannot equip the hospitals, and we don't have the manpower to even man those ventilators and manage those complex patients. We don't have enough of them that are trained. So our best bet is to catch it early and stop it from overwhelming our country and our healthcare system.
Prof, any thoughts? Your thoughts on this too?
Yeah, I think for awareness, the thing that stands out to me the most is stories. I think there's a power to stories, and very easy not to take COVID-19 serious, but there are stories you hear that can shake you to the core. And I think even Italy had lots of cases, and they recorded all these people talking. They were recording themselves on the phones. I wish I had known this was serious, and they had some sort of campaign. And now Nigeria is having some powerful stories that we can use to motivate people to stay at home. From the Melinda Gates perspective of Africans will be falling off the streets and dying, I actually like to think that way myself. Like, we should hope for the best, but try to prepare for the worst. The way I'm viewing it, imagine that in November 2019, someone comes to you and tells you 25 million Nigerians died from COVID-19. You look around for your people, you're struggling to find them. Where are they? You're trying to get in contact with people. It's not happening. Now, if you are given a second chance to come back to today, what would you now do going forward, right? What would you do to prevent that catastrophe from happening? That's kind of how I'm trying to think in my mindset, because I think that would cater to the diaspora as well, because the diaspora, everyone is very hopeful, but we're not preparing for the worst. Everyone's like, yeah, when the pandemic is over, but what if the pandemic is not over, right? We're not prepared at all. So I feel in that way, we should also be assessing what we can do to the best of our ability. There are lots of efforts. That's kind of my standpoint on both of them. I hope what Melinda Gates says does not happen, but we have to start thinking, how do we prepare for that to prevent it?
Thank you, Prof. Dr. Kelechi, your thoughts?
Okay, well, I think sending out the message is going to be very difficult. There are some people that understand the message, and there are some people that don't understand the message. The message exactly is that coronavirus is different from your regular infection. It's more infectious before it even starts showing symptoms. And if you don't have symptoms, you don't know that you have an infection. Everybody's going to be like, I think I'm well. So if you look at the people who were protesting in the US yesterday, some lady came out and said, well, we know what to do. We'll tell the people who are sick to stay home and the people who are well can go back to work. It doesn't work like that because you don't know who is sick. And then they surveyed, I think, about 300 people in some prison yesterday. 147 of them were positive and none of them had symptoms. So the problem is that the disease does not have symptoms. And communicating that to people is very difficult. Some people might understand it, and some people might not understand it. And then even those that understand it are tired of staying home. And so because they're tired of staying home, they're frustrated and they want to go to work and they want to make a living, all that rationale goes out of their head. So I agree with what Dr. Repover said, storytelling. I remember when I was in Nigeria, they used to do jingles. They will do jingles and they will make it in such a fun story that everybody would remember. I think the only thing I really remember is Andrew is leaving the country or something. And then there was another jingle about, don't do this, don't do that. So I think if you can come up with fun jingles that are very clear cut and let people know the reality. Like you don't see it, but it's there. I mean, I don't know how you can make it look like a juju or something, but it's there, you don't see it, but it's there. And even if you don't see it, it will still get to you. And I think that's what people don't understand. People are waiting to have fever and waiting to have cough and they don't know that they're not going to have it. And so the message is difficult, period. That's what it is. The message is difficult, but we just have to continue trying. And it's not only to Nigerians. I think it's worldwide. Everybody is tired. There's no end in sight. We don't have a vaccine. We don't have a treatment. People are dying. Everybody is scared. So if you could tell them this is where it's going to end, if it's going to end in the end of April or March, then people will respond to that. But nobody. So the message is that. So Honorable Dr. Abiri, Honorable Dr. Abike. Sorry,
I'm not a doctor. I wish I was.
Oh, your name is Abiri. So I'm adding doctor to it. So it's a difficult message to pass out, and it's not easy in any way, form, shape, or size. And I don't think you can win everybody 100%, but the only thing to say is just to keep trying. It's worldwide and people listen and people don't, it's difficult. In terms of Melinda Gates, it's what she said, it's possible, it's not possible, but the truth is, we're seeing what is happening in other countries, we're seeing what is happening in the US, we're also seeing what is happening in Nigeria. So I think that what she says is a possibility. I think that if you make people afraid, they might listen to you. If you say to them, if you don't do this, your body's going to be out on the street. Not really in that way, in a more politically way, you may get results. Okay, a lot of people like Dr. Abel does outpatient medicine, I do inpatient medicine. I'm sure he tells his patients, if you don't stop smoking, if you don't stop drinking, this is going to happen to you. And they don't listen. Then when they come into the hospital and they can't breathe, I tell them that, okay, will you stop smoking? And they're like, yes, I'm not going to smoke anymore.
I'm not going to smoke
every
anymore.
smoker who comes to the hospital quit smoking that day. And then until they go back out again, then they will start. So there might be a way to conjure some of that fear into, this is the outcome we're going to look into if we don't start. And let me just, one more thing I'm going to add. I think when the US started, when Dr. Fauci started talking, there was an extrapolation that we're going to have over 200 million people dying. And they said, unless we set social distancing. And I think that scared people into social distancing. And now the numbers have come down to 60,000. So it's the same thing you have to project in Nigeria. If you don't social distance, our numbers are going to go higher. But if you social distance, you can bring down our numbers and you can use various funds to different examples. Taiwan is a good one. Taiwan is a very good one. So that's what I think.
Thank you. Thank you very much.
Yeah, thanks so much. We've run like way out of time, but I think very engaging conversations out here. Just try to wrap up here. Just one last comment I want to throw out here. Somebody just came in and I just want somebody to answer. Maybe Dr. Chus can answer this. Someone posted and said, I visited the cinema at Maryland Mall, Lake, Nigeria on the 15th of March. I fell sick around the 24th with mild headache, temperature with fever, clogged throat with cough and chest pain. I was treated with local herb, but the sickness came back when I visited Babcock Hospital. The test was conducted on my blood and it came out with malaria and infection of the throat, and I was administered drugs. All the symptoms are gone now, but still have a mild cough. The question is, does it mean I have coronavirus and need to be tested for it? Dr. Chuk.
The person is suggesting that they are getting better and their symptoms.
Yes, the symptoms are gone, but they still just have a mild cough.
They don't need to be tested.
Okay. Okay.
Yeah. So if I can make a quick
that's good enough.
that, please.
Yes.
Let me make a quick comment, Obina. Listen, malaria is the commonest cause of fever here by far.
Mm-hmm.
Okay. And then just because there's COVID-19, people still have a cold. People still have sore throat from other causes. So there are more cases of sore throat from other causes than do occur as a result of COVID-19. And those other diseases have not gone on holiday because of COVID-19. Right. So yeah, people should bear in mind that they still have malaria, they still have pharyngitis, they still have other things that were always there and will be there even after this outbreak.
Right.
Thank you.
Okay. Okay, cool. Thank you. We've gone way over time, but I think very engaging conversation. Sorry, we're going to have to wrap it up here. Thank you all to the panelists. Thank you, Honorable, for joining us and staying with us. We'll try to do more of this. I think someone even just posted in that, a lot more questions out there. So we'll try to figure out a way to get more sessions in place.
Can I quickly say thank you? Thank you to everybody. Obina, thank you very much. Dr. Korocha, Dr. Chooks, Professor Falari, Dr. Kelechi. You hear from us a lot more because between the four of you, in fact, the five of us were Obina, we have the solution to Nigeria's problems. You can't be out there. Korocha, you're already here, and we have problems. We must work together to build Nigeria. Nigeria is the future. Africa is the future. I thank you and I believe in all of you. Thank you very much.
You're welcome.
Thank you. Thank you.
Thank you. Thank you, everybody.
Thank you.
Thank you. Bye, everyone. All right, guys. Bye.
Bye.
Well done. Right.
Bye.
Bye.
Bye.